Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am currently a PGY5 resident at the University of Pittsburgh. Today we'll begin our next installment of the head and neck cancer series with a discussion on laryngeal cancer. Just to review some of the key anatomy, which we've already talked about in our anatomy lecture, the larynx is located inferior to the oropharynx, and it's located anterior to the hypopharynx. The larynx is divided into three different subsites, which are the supraglottis, the glottis, and the subglottis. The supraglottis is made up of the epiglottis, the arytenoid cartilage, aryepiglottic folds, and then the false vocal cords. The glottis consists of the true vocal cords and their anterior and posterior commissures. And then the subglottis is the tissue that is inferior to the glottis that connects from just beneath the true vocal cords all the way down to the first tracheal ring. So it's a small amount of tissue, and the cricoid cartilage sort of surrounds that tissue, but that is really the subglottis. So we have supraglottis, glottis, and subglottis. The key functions of the larynx are, number one, to protect our airway when we are swallowing, so it prevents any food or saliva from entering our airway. And number two, the function is to help with phonation, right? So the vocal cords are part of the glottis, and the larynx helps us to talk and create sound and cough and things like that. So those are kind of the two main functions of the larynx, and the most important, arguably, is to protect the airway. In terms of some epidemiology, we know that laryngeal cancer is a little bit more common in men compared to women, and it's actually much more common in South Asia compared to the US. In terms of where these cancers originate, so the majority of laryngeal cancers actually originate in the glottis, so usually in the vocal cords, so about 2/3 of laryngeal cancers start out in the glottis. About 1/3 start out in the supraglottis, and then a very small minority, so only 1 to 2%, actually start in the subglottis. In terms of lymphatics, the supraglottis and the subglottis have extensive lymphatics, and anytime a tumor is invading into the subglottic larynx, we actually think about covering level 6, which are the nodes that are located kind of anterior to the larynx and to the trachea. And the one exception to the extensive lymphatic drainage that we see for most head and neck cancer sites is actually the glottis. So if we have an early stage tumor involving just the glottic larynx, so a T1 to T2 N0 glottic laryngeal cancer, these tumors actually have a less than 5% chance of spreading to regional lymphatics. And so that is the one disease site where we can cover a very small field and don't necessarily have to chase after regional lymphatics. So tumors of the glottic larynx tend to have very, very sparse lymphatics. But if those tumors become more advanced and if they start to encroach upon the supraglottis or the subglottis or any other structures, then we start to think about covering regional nodes because these other surrounding tissues do have extensive lymphatics. So with that introduction in mind, let's get started with the talk. What I'd like to do here is to, as always, go through some of the background, including presentation, workup, and then staging of laryngeal cancer, talk about some of the key aspects of the treatment paradigm, and finally get into the evidence for why we do what we do when it comes to laryngeal cancer. Starting with a little bit of background on the presentation and workup. The most common presentation of laryngeal cancer, especially early stage glottic cancer in particular, is hoarseness. Patients may also have symptoms such as dysphagia or a globus sensation. They may have cough, hemoptysis, or stridor. And otalgia can also be associated with laryngeal cancer. So the reason for this is that the larynx is innervated by branches of cranial nerve 10. So the internal and external branches of the superior laryngeal nerve innervate the supraglottic larynx. And then one of those branches of cranial nerve 10 is something called Arnold's nerve, which innervates the inferior and posterior external auditory canal, the concavity of the concha of the ear, as well as the lateral tympanic membrane. So if you take a look at the diagram, kind of that middle portion of the ear, including the external auditory canal, is innervated by Arnold's nerve, which is a branch of cranial nerve 10. And we also know that branches of cranial nerve 10 supply the supraglottic larynx. So that is sort of the connection between Arnold's nerve and the external canal of the ear and otalgia that we see with laryngeal cancer. Remember when we reviewed oropharyngeal cancer, we also talked about the possibility of getting some ear pain? That otalgia is actually otalgia of the middle ear, because the middle ear is innervated by something called Jacobson's nerve, which is a branch of cranial nerve 9, or the hypoglossal nerve. So middle ear pain tends to occur more with oropharyngeal tumors, so things that are involving the base of the tongue especially, because that's related to the hypoglossal nerve. And then the external auditory canal pain is more associated with Arnold's nerve, because that is a branch of cranial nerve 10, and cranial nerve 10 also has branches to the supraglottic larynx. So think of oropharyngeal cancer ear pain being more of the middle ear, laryngeal cancer ear pain being more related to the outer ear, or that external auditory canal. I don't want to belabor the workup too much because we have talked about this and it's very similar for many of the other head and neck sites. But as always, we start with a history and physical, full cranial nerve and cervical lymph node examination. A flexible nasolaryngoscopy is useful to evaluate the primary tumor and vocal cord mobility. And ENT doctors may often perform a video stroboscopy to actually evaluate the mucosal wave of the vocal cords. In terms of imaging, again, very standard across the different head and neck disease sites. So we always get a CT neck with contrast, CT chest without contrast. You can consider a PET CT for nodal as well as distant staging, especially for more advanced tumors of the larynx. And then we consider an MRI if there is any concern for perineural spread. In terms of pathology, an exam under anesthesia and a triple endoscopy with biopsy, so laryngoscopy, bronchoscopy, and esophagoscopy is recommended. And then finally, for all patients that are getting head and neck radiation, we always refer them for dental evaluation to have tooth extractions prior to radiation and fluoride treatment during and after radiation, speech, swallow, and nutritional evaluation, audiology, especially if they're going to be getting chemotherapy, and then smoking cessation counseling if applicable. Just to review some anatomy a little bit in detail, the larynx spans from about C3 to C6 vertebral levels, and the boundaries of the larynx superiorly are the hyoepiglottic ligament, inferiorly the bottom of the cricoid cartilage, so the cricoid cartilage actually wraps around the subglottic larynx. Anteriorly, it's bounded by the thyroid cartilage and the thyrohyoid membrane. And posteriorly, the boundary is the arytenoid cartilage. So there are a lot of cartilages that surround the larynx. And if you want to look closer at that anatomy, I have some slides going through CT sections, CT scan slices, kind of pointing out those individual cartilages in the anatomy talk. So those are kind of the boundaries of the larynx, many important cartilages, which are important landmarks to keep in mind. The laryngeal muscles are mostly innervated by the recurrent laryngeal nerve, which is a branch of cranial nerve 10. And if those muscles are damaged, that leads to a fixed midline cord, and it causes hoarseness because of vocal cord paralysis. So if the recurrent laryngeal nerve is damaged, what we see symptomatically is hoarseness. Now, the one muscle that's not innervated by the recurrent laryngeal nerve is the cricothyroid muscle. That's actually innervated by the superior laryngeal nerve, which is also a branch of cranial nerve 10. And damage to that superior laryngeal nerve causes mobile cords, but they're bowed. And that ends up leading to a lower pitched voice where you cannot hit high pitched notes as well. So remember, recurrent laryngeal nerve causes hoarseness if damaged. Superior laryngeal nerve, if damaged, causes inability to hit those higher pitched notes. So in med school, we learned that's the nerve that opera singers don't want to damage because then they can't sing as high. So think superior, high, and that affects your high pitched voice. So superior laryngeal nerve causes bowed but mobile cords, leading to a lower pitched voice. And just to reiterate some key points about lymph node drainage, remember we said the supraglottis and subglottis have extensive lymphatic drainage, just as many of the other head and neck cancer sites do. The glottis is sort of the one exception to that rule with very sparse lymphatic drainage. So the supraglottis drains typically to levels 2 through 4 bilaterally. And if we have involved nodes within 2 through 4, then we apply some of those same principles where if, say, a level 2 node is involved, then we think about covering adjacent levels such as 1B and 5 on that ipsilateral side. The glottis, as we said, has very, very sparse lymphatic drainage. So early stage glottic disease rarely involves lymph nodes. So for a T1 and 0 glottic cancer, the risk of lymphatic nodes being involved is around 2%, and it's around 5% for a T2 and 0 glottic cancer. So very, very low chance of regional lymph node involvement. And so we often don't cover any regional lymph nodes when we're treating glottic cancer. Subglottic cancer, however, has extensive lymphatic drainage as well, and not only does it drain to levels 2 through 4 bilaterally, it can also drain to level 6, which are the pretracheal, or also known as the Delphian nodes. So these nodes are located sort of anteriorly to the larynx and the trachea in the space superiorly bounded by the hyoid bone, and inferiorly bounded by the top of the sternal notch. So those kind of nodes that are anterior to the larynx and the trachea, or those pretracheal nodes, those are the level 6 nodes. And anytime there is a subglottic tumor or any extension into the subglottis, then we think about covering those anterior level 6 nodes as well. Moving on then, let's talk a little bit about staging of laryngeal cancer. The T staging for supraglottic versus glottic versus subglottic laryngeal cancer is a little bit different. They have very similar principles across the T stages, but technically they have a different T staging system based on the subsite. So let's start with what's common between the different T stages, and then we'll kind of one by one go through the different subsites. So what is common for these three subsites in terms of their T staging? T1 is typically normal vocal cord mobility. T2 is typically if there is impaired vocal cord mobility, but not immobile vocal cords. So impaired vocal cord mobility is typically T2. And then fixation of the vocal cords, meaning that they are completely immobile, is T3. And then T4 is similar or is identical for all three of the disease sites. So T4A is if we're invading through the outer cortex of the thyroid cartilage or any tissues beyond the larynx. So think trachea, soft tissues of the neck, including the deep muscles of the tongue, strap muscles, thyroid, or esophagus. So kind of through the thyroid cartilage and different soft tissues of the neck. If it's involving the prevertebral space, encasing the carotid artery, or invading any mediastinal structures, then it is considered T4B. So T4A is through the outer cortex of the thyroid cartilage. T4B is into the prevertebral space, encasing the carotid or any mediastinal structures. So T4A, T4B are identical between these three subsites. And then T1, remember, generally is normal vocal cord mobility. T2 is impaired vocal cord mobility, and T3 is fixation of the vocal cords, or in other words, immobility of the vocal cords. So now one by one, let's go through the different subsites and talk about T1 to T3, which are subtly different. So for supraglottis, T1 is anything that's limited to one subsite of the supraglottis with normal vocal cord mobility. So remember the four subsites of the supraglottis, right? We have the epiglottis, the arytenoid cartilage, the aryepiglottic folds, and then the false vocal cords. So as long as it's limited to one of those subsites, it's considered T1. If we have two or more subsites involved, or any adjacent structures such as the base of tongue, the vallecula, the medial wall of the piriform sinus, without fixation of the larynx, then it's considered T2. If we have fixation of the vocal cord, or invasion into the inner cortex of the thyroid cartilage, or invasion of any of the three Ps, so the three Ps are the postcricoid area, the pre-epiglottic space, and the paraglottic space, then it's considered a T3. So don't confuse the three Ps with the medial wall of the piriform sinus. If we're invading the medial wall of the piriform sinus, it's still T2 for supraglottic. However, if we're invading the 3 Ps, and the 3 Ps are postcricoid cartilage, pre-epiglottic space, or para-epiglottic space, then it's considered a T3 tumor. Or if it's going to the inner cortex of the thyroid, or if the vocal cords are not moving, if they are fixed, then it's T3. So supraglottis is probably the most confusing staging. Glottis is a little bit more simple. So T1 is divided into T1A and B, with T1A being limited to 1 vocal cord and T1B being limited to 2 vocal cords. And again, vocal cord mobility is normal for T1, so the mobility has to be normal. T1A is 1 cord, T1B is 2 cords. T2 is if it extends to the supra and or subglottis, or with impairment of the vocal cord. So if there's any impaired vocal cord mobility, then it's automatically T2, or if it's extending to adjacent sites, so supra or subglottis, it's T2. T3, as always, is if the vocal cord is fixed, or if there's invasion of the paraglottic space, so again, that's one of the 3 Ps, or the inner cortex of the thyroid cartilage. So T3, again, is very similar between glottis and supraglottis. And then finally, we have subglottis. So T1 is if it's limited to 1 subsite of the subglottis, or rather just limited to the subglottis. T2 is if we have extension to the vocal cord with either normal or impaired vocal cord mobility. If it's extending to that adjacent site, it's automatically T2. T3 is if we have fixation of the vocal cord or involvement of the inner thyroid cartilage, the inner cortex of the thyroid cartilage. So again, T1 to 3 are a little bit different between the 3 subsites, but the general principles are identical across all 3. So T1 is if you're limited to 1 of the subsites with normal vocal cord mobility. T2 is if you're going into adjacent structures and you can have impaired vocal cord mobility. T3 is if you have fixed vocal cords or invasion of those 3 Ps, so postcricoid area, preepiglottic space, paraglottic space, invasion of the thyroid, the inner cortex of the thyroid cartilage, that makes you T3. And then once you're through the outer cortex of the thyroid cartilage, it's T4A and beyond. I'm actually not going to read through the nodal staging because we have actually reviewed this multiple times within our head and neck cancer series, because believe it or not, the clinical and pathologic nodal staging for laryngeal cancers is identical to that in P16 negative oropharyngeal cancer, and it's also identical to what we see for oral cavity cancer. So I've already kind of gone through this twice before. So hopefully if you've been following along with the head and neck cancer series, you've had a chance to watch those lectures and kind of go through this clinical and pathologic nodal staging. This is a little bit of a beast to memorize, but the good thing is once you memorize it for one disease site within the head and neck, it applies to many of the other disease sites within the head and neck, including oral cavity, P16 negative oropharynx, as well as now laryngeal cancer. So the clinical staging is divided based on the side, the ipsilateral versus contralateral location, and then also if there's single versus multiple nodes. So that's sort of how the clinical staging works, and any node with clinically overt extranodal extension is automatically clinical N3B. And then the pathologic nodal staging is completely identical to the clinical nodal staging, with the one difference that if you have a single ipsilateral node measuring 3 centimeters or less with extranodal extension, then that is actually N2A. But it's only if you have one ipsilateral node that's smaller than 3 centimeters with ENE positive. It's a pathologic N2A, but a clinical N3B. But any other case of ENE, or if you have multiple nodes with ENE, then it's still N3B pathologically. So the clinical and pathologic nodal staging, again, there's a lot to memorize here. For the sake of time, and because we've gone through this before, I'm not going to rehash and focus a lot on this. But the good thing is once you memorize it for one disease site within the head and neck, it applies to many other sites as well. So hopefully, if you haven't already, you can watch some of the other lectures where we've spent more time kind of belaboring this and hopefully get it ingrained in your memory. The group staging for laryngeal cancer is also fairly straightforward. So T1N0 is stage 1, T2N0 is stage 2, and everything else is stage 3 or 4. So if you have T3N0 or 1, you're automatically stage 3. Or if you have T1 to T2N1, you're automatically stage 3. So T3 or N1 makes you at least stage 3. If you have T4 or N2 or anything higher than that, then you're stage 4. So 4A is T4A, N0 to 2, or N2, T1 to T4A. If you are N3 or if you're T4B, then you're stage 4B. And then if you have any distant metastases, you're stage 4C. So pretty simple. Again, T1N0 is stage 1, T2N0 is stage 2. If you are T3 or N1, you're automatically stage 3. If you are T4A or higher, or if you are N2 or higher, then you're automatically stage 4. So we probably got through the background and staging for laryngeal cancer a little bit faster than we've done for some of the other disease sites. And that's just because there are a lot of similarities between the different subsites of the head and neck. So the good thing is that we can kind of rely on those similarities and apply those general principles across all the disease sites. But really with these kind of site-specific lectures, my goal is to really highlight the differences and kind of the unique data sets that we have when it comes to specific subsites. So again, as we go through treatment paradigm, what we will see is that the general principles of radiation dose are largely very similar for laryngeal cancer, and the general principles for postoperative radiotherapy are also very, very similar to what we have previously talked about. There's just some unique considerations as to when we think about surgery versus radiation for laryngeal cancer. And as we said, with the early stage laryngeal cancers, so T1 to T2N0, we actually treat them with radiation alone to a smaller field using a slightly hypofractionated dose. So let's get into the treatment paradigm and kind of highlight some of these key differences in the management of laryngeal cancer, and then we'll get into the evidence. So like most other cancer sites generally, even with lung, breast, and so on, we always think about dividing localized cancer that's limited to either the primary tumor and or lymph nodes. We always think about that in the context of early stage versus locally advanced. So early stage is typically smaller tumors without lymph node involvement. Locally advanced is typically larger, more invasive tumors, and oftentimes with lymph node involvement. So same principles for laryngeal cancer. And with early stage cancer, we have to think about glottic larynx differently from supraglottic and subglottic larynx, because remember, as we talked about, glottic larynx specifically, when it is limited to the glottis, does not have extensive lymphatic drainage, so we can actually omit regional nodal irradiation. So early stage glottic laryngeal cancers are kind of the one exception to the standard doses that we have talked about so far for head and neck cancers generally. So for early stage glottic laryngeal cancer, if it's T1 to T2N0, these tumors are treated with a little bit of a hypofractionated approach. And instead of giving 1.8 to 2 gray per fraction, we actually give 2.25 gray per fraction, just for T1 to T2N0 early stage tumors of the glottic larynx. So 2.25 gray per fraction. For T1N0, we do 2.25 gray per fraction for a total of 28 fractions, which is 63 gray in 28 fractions. If it's T2N0, then we just add another fraction, and it's 65.25 gray in 29 fractions. So T1 is 28 fractions, T2 is 29 fractions, and we're giving 2.25 gray per fraction for T1 to T2N0 glottic larynx tumors. Other than tumors that are T1 to T2 of the glottic larynx, everything else is treated with the standard doses of radiation that we've previously talked about. So if we are treating with definitive radiation, with or without chemotherapy, the standard dose is 70 gray. And again, we can use either sequential or simultaneous integrated boost to treat elective low and intermediate risk volumes to lower doses than that. But 70 gray is kind of the standard definitive dose, the highest dose that we take things to. If we're doing post-operative radiation, again, either with or without chemotherapy, the standard dose is 60 gray. We go up to 66 gray if there is positive margin or if there's extracapsular extension of lymph nodes. So 70 gray versus 60 to 66 gray for definitive versus post-op respectively. So again, we can still divide these tumors into early stage versus locally advanced. So early stage tumors of the supraglottis or the subglottis, remember, these now do have extensive lymphatic drainage, and so we think about treating them the same way that we think about treating, say, an oropharyngeal cancer definitively, where we typically treat the primary and any involved, early stages, no involved nodes. So we typically take the primary to 70 gray, and then we have elective volumes for lower risk areas. So those are early stage supraglottic or subglottic laryngeal cancers. And so when we're saying early stage, we typically mean T1 to T2 N0 and select T3 to N0. Now, if we have a bulky T2 tumor, so kind of something that's on the larger side, or if we have a T3 tumor, meaning the vocal cord is fixed, then we actually think about adding concurrent chemotherapy. In select cases of these early stage supraglottic or subglottic laryngeal cancers, we may be able to consider larynx preserving surgery, and then we utilize kind of a tailored adjuvant approach depending on their pathologic risk factors. So that's early stage tumors that are of other subsites besides the glottis. And then finally, we have our locally advanced tumors. So these are typically tumors that are T3 to T4 or node positive. And the approach for locally advanced larynx cancer really starts with assessing the function of the larynx. So remember, we said the larynx has two main functions, and the most important is arguably protecting the airway. If the tumor is so advanced that our larynx is not protecting the airway, then that larynx really needs to come out, and there's no point of larynx preserving therapy because we're preserving something that's not working. So if we have a non-functional larynx, the preferred approach is actually total laryngectomy. And then we do adjuvant treatment the same way we think about adjuvant treatment for other sites, right? So 60 to 66 gray adjuvant. If we're taking it to 66 gray for positive nodes or positive ECE, then we think about adding chemotherapy along with the radiation. So if the larynx is not working, we take it out. If the larynx is functional, however, then the goal is to try and preserve the larynx, and we actually prefer treating these with upfront definitive chemoradiotherapy. So if it's a locally advanced laryngeal cancer with a functional larynx, then the preferred approach is definitive chemoradiation. And again, the definitive dose is going up to 70 gray, usually in 35 fractions, and we give concurrent chemotherapy. Oftentimes it's something like weekly cisplatin, 40 milligrams per meter squared. I'd like to get into a little more detail about radiation for early stage glottic cancer. So remember, that is our T1 to T2 N0 glottic laryngeal cancer, so anything involving the vocal cords only. Just because the radiation approach that we use for this cancer is a little bit different than what we use for other head and neck sites. So classically, when we treat early stage glottic cancer, as we talked about, the standard doses that we use are actually hypofractionated. So 2.25 gray per fraction, 28 fractions for T1 N0, 29 fractions for T2 N0 tumors. And traditionally, we have always been delivering radiation using a 3D conformal approach, just using parallel opposed fields. So if you take a look at the image on the right-hand side, you sort of see the standard box that we draw, and it's parallel opposed fields, so kind of laterally treating the larynx. And we just localize our treatment to the larynx for these early stage glottic cancer tumors because, as we said, they don't have very extensive lymphatic drainage. When we use these parallel opposed fields, we typically simulate patients with their chin extended as much as possible because what that does is it allows us to create a box around the larynx and avoid having our radiation beam go through their chin. So we still simulate them in a mask. We just ask them to kind of hyperextend their neck so that their chin is out of the field. When we do these parallel opposed fields, we're not really intentionally covering any elective nodes, but when we use the opposed laterals, we end up inadvertently covering the level 3 nodal space. So this is, 3D radiation is what we have always used, and it's really just in the modern era, like in the last about a decade, a little over that we've really been starting to use IMRT more and more and more. But traditionally, treating an early stage glottic cancer was very simple because it's just a box around the larynx and we use parallel opposed fields. And even though we're not necessarily specifically trying to, inadvertently, we are covering that level 3 nodal space. The field borders for the larynx are a little bit different depending on T1 versus T2. So for T1, remember, this is just limited to the vocal cords alone without any extension into adjacent sites. So for T1 field borders, it's typically a 5x5 field. Superiorly, we start at the top of the thyroid cartilage. Inferiorly, we go to the bottom of the cricoid. We give a flash of 1 centimeter anteriorly, and that means that our beam extends outside of the body 1 centimeter anteriorly. And then posteriorly, we go to the anterior edge of the vertebral body. So it's a 5x5 centimeter box with those borders for a T1 tumor. For a T2 tumor, remember, a T2 N0 tumor is something that's involving the vocal cord with either impaired vocal cord mobility or extension to either the supraglottis or the subglottis. So our borders are the same, but our field is a little bit larger. So it's 6x6 centimeters, and we can actually adjust our superior or inferior border depending on where the tumor is extending. So if the tumor is extending into the supraglottis, we extend 1 centimeter above the thyroid cartilage. Or if it's going inferiorly, we go at least 1 tracheal ring below the cricoid cartilage. So a 6x6 centimeter, a little bit larger than what we utilize for T1, which is 5x5. And our field border should be at least 2 centimeters above or below our GTV. So additional considerations when we're thinking about 3D radiation, the neck is thinner in the front compared to in the midline. And so we do think about adding some wedges with the heels pointing anteriorly, since the neck is thinner there, to kind of help create a more homogeneous dose. And if necessary, we can actually consider, rather than parallel opposed, even a 3-beam arrangement with opposed laterals and a lightly weighted anterior beam. Now, in order to ensure that the anterior aspect is getting enough dose, especially for very thin patients, remember with 3D, we worry about requiring bolus to get adequate dose anteriorly. So what I have seen some physicians do is actually use like a MOSFET device or TLDs at the time of the first treatment and calculate the dose to the skin. And if that dose is less than ideal, then they might actually consider adding a bolus there to make sure that the anterior edge of the larynx is getting enough dose. So that's kind of the most important point I wanted to make, is that for these early stage T1 to T2 glottic cancers, we can treat with just parallel opposed fields and we use a different dose. Now, in the modern era, many practitioners are actually moving towards using IMRT for early stage glottic cancers. And the idea for this is that it can help to actually spare the dose to your carotid arteries. The reason this approach is controversial is because when we're using IMRT, we're able to better shape our dose around the larynx, so we're not actually getting elective nodal coverage of the level 3. And remember, with 3D, it's not like we're trying to cover the elective nodes. We are just inadvertently covering 3D by virtue of how our fields are designed. And a lot of people argue that this is what we've been doing for so long, and this is where all the data comes from, and this is what they have done in these studies, so that is what we should do when we're treating our patients. But there is some retrospective data, and there's a nice meta-analysis that was published in the Red Journal recently that actually goes through many trials that have compared IMRT And it's all based on retrospective data, but the retrospective trials kind of compared IMRT versus 3D, and they found similar rates of local and regional control with carotid sparing IMRT. So some practitioners are moving towards carotid sparing IMRT, but we don't actually have randomized data for this. So it's just something to be aware of, and it's important to realize that when we are using carotid sparing IMRT, then we are not electively covering level 3 lymph nodes. So with that overview of the treatment paradigm for laryngeal cancer, let us get into some of the evidence, and we're going to divide it into early stage glottic larynx versus locally advanced larynx. So let's start by talking about some of the data for why we do what we do in early stage glottic larynx cancers. So the data for hypofractionation for early stage glottic larynx actually comes from Japan. So there's a trial, first author Yamazaki, and it was published in the Red Journal in 2006. And they took 180 patients with early stage glottic cancer, so T1N0 carcinoma of the glottic larynx, and they randomized these patients to either 2 gray per fraction or 2.25 gray per fraction. So the 2 gray per fraction arm got 30 fractions for tumors that were involving less than 2/3 of the cord, or 33 fractions if they were greater than 2/3. So the dose was either 60 gray or 66 gray. And then the 2.25 gray per fraction arm got 25 fractions if it was involving less than 2/3 of the cord, or 28 fractions if it was involving more than 2/3. So their dose ranged from 56.25 gray up to 63 gray and 28 fractions. And they used parallel opposed fields to deliver the radiation, so the 3D planning like we talked about. What they found is that 5-year local control was significantly improved with a moderately hypofractionated arm. So the 5-year local control was 77% in the arm that got 2 gray per fraction, and it was 92% in the arm that got 2.25 gray per fraction. So that's like a 15% improvement in local control with the use of hypofractionation, and that was statistically significant. They found no significant difference in their case-specific survival, so it was 97% versus 100%, not statistically different, but the local control was significantly improved with the hypofractionation. And moreover, they did not see any significant differences in their toxicity, so no change in acute mucosal reaction, skin reaction, or any chronic side effects. So the big takeaway here is that the Japanese hypofractionation study found improved local control with 2.25 gray per fraction for T1N0, M0 glottic laryngeal cancers, and that's sort of the biggest study why we do what we do when it comes to these early stage cancers of the glottic larynx. There was another study out of Korea called the KROG 0201 study. And unfortunately, even though the study was trying to look at hypofractionation, it ended up being a negative trial, but it was also because it had poor accrual. So they only were able to accrue about half of what they planned to. But they took T1 to T2 N0 glottic cancer patients, and again, they randomized them to conventional versus moderate hypofractionation. The biggest difference is that this study also included T2 N0 patients, and they took them to slightly higher doses. So it was 66 to 70 gray for T2 with a conventional arm, or in the moderately hypofractionated arm, they did 63 gray for T1 and then 67.5 gray for T2, again at 2.25 gray per fraction. When they looked at the entire cohort, they found no significant differences in local control or survival between arms, and you can see that the local progression-free survival was numerically about 10% higher in the hypofractionated arm. So it was 78% with conventional fractionation versus 89% with hypofractionation, but that did not reach statistical significance. And again, we can only postulate, but perhaps it was because they did not meet their accrual goal. And then they did perform a subgroup analysis of the T1A patients, and in that arm, they found a greater trend towards significance. So the 5-year local progression-free survival was 77% in the conventionally fractionated versus 99% in the hypofractionated. And again, they did not find any significant differences in the grade 1 to 2 toxicity. But because of the poor accrual and because the primary endpoint was not significantly different, the conclusion is that hypofractionation is at least not inferior to conventional fractionation for early stage glottic cancer. And there's a potential advantage in terms of local control as well as overall treatment time. So again, the previous Japanese study that we mentioned by Yamazaki et al., that's kind of the main trial that showed a significant local control benefit with hypofractionation. KROG 0201 was, I think, almost there, but they had poor accrual and the trial ended up being negative. But again, the conclusion was that hypofractionation is at least not inferior. And so standardly for early stage glottic laryngeal cancers, we treat these patients with 2.25 gray per fraction. And the standard doses that we have moved to are 63 gray and 28 fractions for T1N0 tumors and 65.25 gray and 29 fractions for T2N0 tumors. In terms of technique, I did previously mention that, these older trials looking at hypofractionated radiation, they were all using parallel opposed fields, so a 3D technique. And I have examples of 3D versus IMRT in this image here. And you can see that when we're using 3D radiation, just by virtue of the physics of how 3D beams are delivered, you end up inadvertently treating the level 3 neck. Whereas when we use IMRT, we're able to spare that a little bit better and our dose is more curved around the larynx. So the advantage of IMRT is carotid sparing, and so many have been moving towards a carotid sparing IMRT approach, but unfortunately this has not been tested really in a randomized setting. So there was a nice meta-analysis that was published by Dr. Rezavian et al. In the Red Journal in 2023. And this meta-analysis looked at 15 different studies that were evaluating IMRT for early stage glottic cancers. So 14 of the studies were retrospective and there was only one prospective study. In total, there were 2,000 patients identified and about 800 of them were treated with IMRT. And they found the actuarial local failure rates at 3 and 5 years were 6% and 9%. And the pooled crude rate of regional failure after IMRT was less than 2%. It was 1.5%. When they looked at factors that were associated with increased local failure on a meta-regression analysis, they found that having T2 disease or having grade 2 to 3 histology were significant factors for increased risk of local failure. And when they compared IMRT versus 3D conformal radiation, they found no significant differences in terms of the local failure or the regional failure. And so this is mostly retrospective data, but it shows that there's no significant difference in local or regional control with IMRT versus 3D conformal radiation. So I do think it's something to be aware of, that depending on the physician that you're working with, depending on the institutional practice, there may be a move towards carotid sparing IMRT. But I think that there are still some sticklers out there who feel that because the randomized data that we have utilize 3D conformal and we don't have randomized data suggesting otherwise, the gold standard should still be to use 3D conformal radiation with parallel opposed beams when we're treating early stage glottic larynx. And then the last study I want to point to is this Helsinki study that actually compared radiation versus laser surgery for T1A squamous cell cancers of the glottic larynx. So these are T1A, meaning the earliest stage. So cancers that are confined to one single vocal cord and that do not have any impairment of vocal cord mobility. So this was a very small randomized study, but they took 56 male patients with these T1A squamous cell cancers of the glottic larynx, and they randomized them to either transoral laser surgery or radiation, and they used a dose of 66 gray with a 6 MeV wedge pair. They used many different measurements to assess voice quality. So they used a blinded video strobe where a physician actually performed a video strobe without knowing what type of treatment the patient got. They also used a blinded expert rated voice quality using a particular measurement scale for that. And then they also had patient self-assessed voice quality and impact on ADLs. Their primary endpoint of 2-year voice quality actually showed less hoarseness with the use of radiation. So they found similar voice quality with the modalities, but the transoral laser surgery had a wider glottal gap noted on stroboscopy, as well as a breathier voice noted by their expert-rated measurements on that score system. The radiation group also had less hoarseness-related inconvenience in the patient-reported outcomes. So at 2 years, it looked like there was less hoarseness with radiation compared to transoral laser surgery. And in terms of oncologic outcomes, there was actually very similar outcomes between the arms. So the 5-year survival was about 89%, disease-specific survival 98%, disease-free survival 84%, with just around 3 recurrences in each arm. And the 5-year larynx preservation rates were also very similar, 92% versus 97% between the 2 arms. So again, very small randomized study, but this Helsinki study does suggest that radiation seems to provide superior voice outcomes versus transoral laser surgery for these very early stage glottic larynx cancers. So we've talked about a lot of different aspects of management of early stage glottic larynx at this point, so I'd like to take a moment to kind of summarize the big takeaways here. As we said, early stage glottic larynx cancer can be cured with definitive radiation alone, and just based on that Helsinki study that we talked about, there is a suggestion of better voice quality and decreased hoarseness by using radiation compared to laser surgery. Now, we do have data from Japan that hypofractionation leads to better local control, and that's sort of the preferred dose fractionation regimen. And again, this dose fractionation is unique for glottic larynx, early stage glottic larynx cancers compared to other sites within the head and neck. So the dose for T1N0 is 63 Gray and 28 fractions. The dose for T2N0 is 65.25 Gray and 29 fractions. And classically, we treat with parallel opposed fields, and I would know kind of the field size and the borders that we reviewed previously for board purposes, and realize that in practice, in the modern era, many folks are moving towards IMRT just because IMRT allows for improved carotid sparing, possibly decreased rate of cerebrovascular events. But that is still a little bit controversial in the field. So for boards, for now, I would probably still stick to the opposed laterals. For every other laryngeal cancer, so anything that's not a T1 to T2 N0 squamous cell carcinoma of the glottic larynx, the standard radiation paradigms are very, very analogous to what we went over in the general principles lecture. So again, definitively, we do 70 Gray in 35 fractions, and in the post-op setting, we do 60 to 66 Gray in 30 to 33 fractions. And the same kind of considerations for when we think about adding concurrent chemotherapy with our radiation, as we talked about in the general principles lecture. So for the general overview and general principles and all the data behind that sort of dose fractionation regimen and the considerations for adding chemo, I would refer you to the general principles lecture, which I previously did in this head and neck cancer series. What I'd like to do in terms of data specific to laryngeal cancer is talk about a few different trials looking at locally advanced larynx, and mainly looking at 2 studies looking at larynx preservation and then the role of adding chemotherapy along with the radiation when we're doing larynx preservation. The VA larynx study is the most important study that you probably need to know for locally advanced laryngeal cancer because it compared surgery to a larynx preservation approach. So this study ran across different VA centers, and it recruited around 332 patients with stage 3 to 4 squamous cell carcinoma of the larynx. And keep in mind that these publications were all in the 90s, so this is a fairly old study. But they took stage 3 to 4 larynx cancer patients, and they randomized them to either surgery followed by postoperative radiation versus a larynx preservation approach. And what they did in their larynx preservation approach is they first gave these patients induction chemotherapy, cisplatin 5-FU every 3 weeks for a total of 3 cycles. After the third cycle, or actually right before they got the third cycle of chemotherapy, they reassessed these patients for their response. So it was given about 18 to 21 days after cycle 2, so literally right before that final cycle of chemotherapy. If patients had at least a 50% reduction in the tumor size, defined as either a complete response or a partial response, so at least 50% reduction in the tumor size, then they went on to get their third cycle of chemotherapy, followed by definitive radiation to a dose of 66 to 76 gray, so around 70 gray. So 3 cycles of chemotherapy. Right before that third cycle, they had to have at least a 50% reduction in the size of the tumor. And if that was the case, then they went on to get definitive radiation after the induction chemotherapy. If they did not have at least a 50% response, or if they had progression of the disease, then they got surgery followed by postoperative radiation. So they basically gave these patients induction chemotherapy, and if they looked like they were responding, they went on to get radiation definitively. So when they looked at their results, there were about 31% of patients that had a complete response to induction chemotherapy and 54% that had a partial response after the 2 cycles of that induction chemotherapy. The combined rates of complete or partial response were 85% after 2 cycles and 98% after 3 cycles. Their outcomes were actually pretty good because their 2-year overall survival was very similar between both arms. It was 68% regardless of the arms. The local failure rates were actually higher with the chemo and then the radiation, so 12% versus 2%. But then the distant metastasis rate were higher in the patients that were managed with surgery followed by post-op radiation. So it was 17% distant metastasis in the surgery arm versus 11% in the patients that got chemo followed by radiation. The most important number that you have to know is that the larynx preservation rate with the induction chemo and radiation was 64%. So the induction chemo radiation actually really worked, right? Because there was no compromise in the overall survival. Yes, they have different patterns of relapse because patients that have chemo tend to have less distant metastasis, and patients that don't have chemo tend to have more distant metastasis. So that's not unexpected at all. But the key takeaway here is that 64% of patients had larynx preservation, which means that, we're able to preserve the larynx in about 2/3 of our patients with locally advanced larynx cancer. And if we're able to do that, then maybe we can improve their quality of life. We know that, this is a significantly morbid surgery. It causes high rates of depression and even suicide and suicidal ideation. So if we can preserve the larynx, that is a huge win for our patients. So 64% larynx preservation rate with induction chemotherapy followed by radiation. When they looked at the T stage, they found that 56% of patients that had T4 disease required laryngectomy versus only 29% of patients that had less than T4 disease. So that makes sense too, right? If the tumor itself is more locally advanced, and if it's T4 starting to invade into things outside of the larynx, then these patients are probably going to not respond as well to the induction chemo. So the big takeaway from the VA larynx study is that this trial had 2 arms. It was comparing surgery followed by post-op radiation to an induction chemo followed by radiation approach with the goal of larynx preservation. And the study showed no significant difference in their overall survival and a 64% larynx preservation rate with that induction chemo followed by radiation approach. So that is the big takeaway from the VA larynx study, is that larynx preservation is possible. The other super important study for locally advanced larynx cancer that we need to know is RTOG 9111. And it's a nice follow-up to the VA larynx study because the VA larynx study told us that, okay, we don't just need to do surgery followed by post-op radiation. There is a possibility of larynx preservation in about 2/3 of our patients with chemotherapy followed by radiation. RTOG 9111 asked in turn, well, what is the role of chemotherapy? Do we actually need chemotherapy? And is it better to give it before the radiation or should we give it concurrently with the radiation? And so based on those questions, this trial had 3 arms, and it enrolled 550 patients with stage 3 to 4 squamous cell carcinoma of the glottic or supraglottic larynx, and these patients were randomized to one of 3 arms. The first arm was sort of their control arm, and it was the winning arm from the VA larynx study. So just like the VA larynx study, they took patients and they gave them 3 cycles of cisplatin and 5-FU. And if they had at least a 50% response after the first 2 cycles of chemo, they went on to get the last cycle of chemo and radiation to a dose of 70 gray. So just like the VA larynx study. The other 2 arms were radiation of 70 gray with concurrent cisplatin, and they gave 100 milligram per meter squared every 3 weeks for a total of 3 cycles, or they gave radiation alone. So the 3 arms were induction chemo, concurrent chemoradiation, or radiation alone. And in all groups, they performed salvage surgery if they had a biopsy-proven persistence or a subsequent recurrence. Their primary endpoint was laryngectomy-free survival, and it was the same with induction chemo or concurrent chemo, but it was significantly worse with radiation alone. So with induction chemo, the laryngectomy-free survival was 29%. With concurrent chemo, it was 24%, and with radiation alone, it was 17%. And when they did the analysis, radiation alone was significantly worse, but induction versus concurrent chemo were not significantly different. They then published a 10-year update and actually showed an improved larynx preservation rate and local control in the concurrent chemoradiation arm. So the larynx preservation was 68% with induction therapy versus 82% with concurrent radiotherapy, and then 64% with radiation alone. So somewhere in the 60s compared to 82% larynx preservation rate, with the winning arm being concurrent chemoradiation. Same thing for local control. The local control was 69% with concurrent chemoradiation, but it was in the 50% range for induction chemo or radiation alone. So this is probably the case because giving the concurrent chemo with the radiation helps the radiation to work better, right? They act synergistically. So we saw the best larynx preservation and local control rates with a concurrent chemoradiation arm. And the overall survival was not significantly different between any of the arms. So the 10-year survival was just around 30% across all of the arms. So the key takeaway from RTOG 9111 is that it was a follow-up to the VA larynx study. The VA larynx study told us that larynx preservation is a possibility if we give a combination of chemotherapy and radiation. And in that study, they used induction chemo followed by radiation. And then RTOG 9111 was kind of a follow-up, and it asked, well, what is the role of chemotherapy? Do we need it? And if so, when do we give it? And it found that, yes, we do need the chemotherapy, but the best time to give it might actually be concurrently with the radiation rather than as induction. And RTOG 9111 showed a very similar laryngectomy-free survival for induction chemo followed by radiation versus concurrent chemoradiotherapy. And what they found is that with the concurrent chemoradiotherapy, there was actually improved local regional control and larynx preservation rates. So typically we don't give induction chemotherapy unless, we can think about induction immunotherapy or systemic therapy if patients are not even a candidate for definitive chemoradiation. But typically these patients are treated with definitive chemoradiotherapy if they have a functional larynx. So the big takeaway here is that locally advanced laryngeal cancers should be treated with concurrent chemoradiotherapy. So this is typically T3 to T4 or node positive. And for high-risk T2 tumors, we can also consider concurrent chemotherapy. So this is case by case, but if there's subglottic extension, impaired vocal cord mobility, which is the old T2B and the older staging system, or if there's bulky disease, and there's really no strict cutoff size for that, but if the lesion does appear larger, if it's on the bulkier side, we can consider adding concurrent chemotherapy. 70 gray is kind of the standard dose, so 70, 63, and 56 gray, all delivered in 35 fractions as a simultaneous integrated boost is one option. You can also consider a sequential boost. And if we're giving chemotherapy, the concurrent chemo is cisplatin weekly 40 milligrams per meter squared or 100 milligram per meter squared every 3 weeks. If they are not a candidate for cisplatin, we can consider other systemic agents such as cetuximab or carbotaxol. And then remember, in terms of elective nodal coverage, so levels 2 through 4, we typically cover bilaterally. If they are node positive, we try to cover level 5 at least on the side of the involved nodes. And if there is subglottic extension or if it's a subglottic primary, then we cover the level 6 Delphian nodes as well. So that brings us to an end of our discussion on laryngeal cancers. Again, we never have time to go over every single study that has been done, but hopefully in this talk I was able to allude to some of the general principles that we have previously talked about, which thankfully are similar for many of the head and neck disease sites. And then my main goal here was to kind of point out some of the key highlights about the differences in management for laryngeal cancer compared to other disease sites, and especially the T1 to T2 and 0 glottic cancer, so early stage glottic cancer, the fact that it's hypofractionated, the fact that we don't need extensive regional nodal irradiation, and the technique with the opposed parallel fields. So hopefully this was a useful talk and you understand larynx cancer a little bit better. I will be planning to continue the head and neck series with the next lecture on nasopharyngeal cancer, and then maybe we can move on to some other disease sites. But thank you so much for your time and attention, and good luck with studying.